All right, good morning, everyone. I'm very happy to be here, and thanks for the Cardiomyopathy Association, Cardiomyopathy UK, to invite me here to give a talk about arrhythmogenic right ventricular cardiomyopathy. And I will try and take you in the next 45 minutes through the topic. Hopefully, there will be some time left in the end to answer some of the questions. Otherwise, we will just push them through to the Q&A session. So when we're talking about cardiomyopathy, it's really about the shape of the heart, and I'm sure you've heard quite a bit about that today as well as in the past. And these are MRI scans from different people with different cardiomyopathies. On the left, you can see a normal MRI scan. This is the left side of the heart and the right side of the heart. And this is a patient with a hypertrophic cardiomyopathy. You can appreciate the thickening of the heart muscle. Here is somebody with a dilated cardiomyopathy, which essentially shows the enlarged left side of the heart. And here is a patient with an arrhythmogenic right ventricular cardiomyopathy. You can see here, we can appreciate the difference in the right ventricle compared to the normal scan there. Now, in terms of the arrhythmogenic cardiomyopathy, where it takes its name. So essentially, it's a cardiomyopathy. And when you talk about that, it's a heart muscle disease, and it's a genetically determined heart muscle disease. That's what we call a cardiomyopathy. And it's characterized by fibrofibrous scar tissue and fat replacement of the normal myocardium. And this can happen both in the right, but also in the left ventricular myocardium. And it's called arrhythmogenic because it's really characterized by ventricular arrhythmias and sudden cardiac death. And this you can see here just a specimen from a heart from a patient with arrhythmogenic cardiomyopathy. This is all the fat replacement in the right ventricle. You can see here the microscopic analysis, but also here the typical arrhythmias, the ventricular arrhythmias that can occur. Now, it is a bit difficult always to assess exactly how common some cardiomyopathies are. But in the case of arrhythmogenic cardiomyopathy, we think it's around 1 to 2,000 to 1 to the 5,000 of the general population. It really comes down to registries, countries, how close people are looking at and the diagnosis. And you can see here these are different registries from sudden cardiac death. And you can see in the UK, we think it's roughly about 10% of the sudden death syndromes. In the US military, obviously, it seems to be quite less given to the screening. It's about 1%, and in the registry, 4%. And in the national registries, around 3-4%. So I think these are probably the numbers. And we know that in about 11% of the sudden death in young adults, the ARVC is really the cause of that. Now, we said it's a genetic disease, and there are the most common cause as desmosomal gene mutation. So we'll talk in a minute about what the desmosome is. And so in roughly 40 to 50% of the patients with arrhythmogenic cardiomyopathy will find the mutation in one of those genes. But now we have expanded our knowledge, and we know that there are non-desmosomal, so there's genetic mutation outside of the desmosome, such as the lamin mutation, which is a nuclear gene, the filament C, which is in the cytoskeleton, but also some other mutations. But more importantly, also some inflammatory cardiomyopathies may produce very similar phenotype with the arrhythmogenic cardiomyopathy. And unfortunately, about in 10 to 20% of the cases, we don't really have a specific cause, or we never find the diagnosis. And this is the desmosome. Essentially, the desmosome is the area that connects the heart muscle cells to each other. And it's very important for a couple of functions. One is to keep the cells together, obviously, which is important for the function, but also transmit the electrical activity and the conduction between the cells, which is also important for the function of the heart. And you can see here, I've marked as red, the most important proteins that we know mutations in these proteins can cause arrhythmogenic cardiomyopathy. And these are classically the desmoplakin, the plakophilin, plakoglobin, desmoglein, and desmocolin. As I said, there are quite a few other proteins outside of the desmosome that can do that, but these are the original that we describe primarily, and we know are the most common ones. Now, a little bit about the inheritance in the ARVC. And as you may remember or may have heard, there is mostly two ways of inheritance. And in most of the cases in arrhythmogenic cardiomyopathy, we're really talking about now an autosomal dominant pattern of inheritance. So essentially, every person has two copies of the same gene, and we only need one to potentially develop the condition. You can see here, this is the father and the mother. mother is a carrier, is affected, and there's a 50% chance of passing on the genetic gene change and potentially to the children. Whereas there are some forms in arrhythmogenic adenopathy. So this is the most common inheritance, but there are some that are autosomal recessive, and these are the Naxos disease and Kaplan syndrome. Whereas, the Naxos disease, which you need both parents to be carrier of the mutation, and the inheritance pattern is 25% in that case. Now, I'll just talk to you a little bit about that. I think that's an important question, whether every gene carrier will develop ARVC. And now we're talking about two things. One is the penetrance, and this describes how many individuals who actually carry the gene change will develop a condition. And the expressivity, which essentially describes the variation in the severity between individuals that carry the mutation and have a condition. So, and as you can see here, there is a very variable penetrance and expressivity. So not everybody is going to develop the condition, and if they develop the condition, there will be a large variation. And penetrance is mostly incomplete in most of the cases of arrhythmogenic adenopathy with a pretty high variation. And there are a number of reasons for that. Whereas in Naxos disease, the approach is 100% penetrance. Now, this is the threshold theory about what factors play a role in developing the condition. Is imagine a theoretical threshold of actually developing the disease or of showing the condition. And you can see here some of the important factors that play a role in development of that. And if somebody has multiple mutations in the desmosome, then obviously the genetic background is going to be the more important determinant of developing the disease. But then, as you can go to the single desmosomal mutations, or even in absent genetic information, you can see here that factors such as sex or exercise start taking up more effect on the expression of the disease and how much an individual will develop the condition. So essentially, when we have a desmosomal gene mutation, we have a lot of, there's a remodeling in the desmosome. There will be some disruption in the function. And as you remember, in the desmosome, there are quite a lot of other proteins and ion channels that play an important role, both in the electrical activity as well as in the contraction of the heart. And this change a lot, and they can be remodeled when we've got a mutation. And a lot will in the ARVC, a significant role will play the external modifiers, such as exercise, as we discussed, potentially viral infection, the immune system, or the presence of additional mutations. So essentially, we've got some remodeling. We may need to electrical instability with the ventricular arrhythmias, and potentially the myocyte loss, and the scar tissue and fat tissue replacement. These are normal. So fat tissue and scar tissue replacement is part of the normal repair mechanism of the body. And this is what happens in the heart as well. But this can cause electrical instability in arrhythmogenic adenopathy, especially in the heart. Now we tend to recognize more the role of the immune system and the inflammatory response in arrhythmogenic adenopathy. And this is a patient with Naxos disease who presented a few years back with palpitations and some atypical chest pains. You can see here he's got a typical skin changes, which I'm sure going to show you in a bit. And when he presented, he showed some troponin elevation, which is a marker of cardiac damage. He had a normal ECG, but you can see here that quite fast on the day 8, and then on month 4, he developed typical ECG changes with development of arrhythmogenic adenopathy. And you can see here this is a sign of potentially a hot phase, what we call, where there is increase of the cardiac troponin, a sign of potential cardiac damage. And we can see here in the typical MRI scan potentially uptake or swelling of the heart and progression of the fibrosis. So now we know that these hot phases can happen in the arrhythmogenic adenopathy, and we think there may be a step up of the phenotype. Now, our knowledge in the last years has significantly progressed. You can see here the amount of publications in the last year in PubMed for arrhythmogenic adenopathy. And from the original description back in 1997 by Guy Fontaine in Paris, And this is one of the first reports as well, from Frank Marcus in 1982, where he actually described in 24 patients with arrhythmogenic cardiomyopathy the typical ventricular arrhythmias, the epsilon wave, and the typical ECG abnormalities in the individuals. But as well, at the time, we didn't really have much imaging opportunities, and you can see here this is a ventriculogram of the right ventricle, where you can see a dilated right ventricle with aneurysms and the histological analysis. But we have moved quite significant, and this is a paper by Corrado a few years back. We can see here the change and the progression in the name, but also the understanding of the arrhythmogenic cardiomyopathy. And now, are we really talking about right? Remember, I put in brackets the right. Are we talking about left, or are we talking about both ventricles affected? And here is just one of these studies that looked into that, quite recent one. And with our progression in the imaging abilities, we, the authors here could differentiate between isolated right ventricular involvement, with histological analysis and right vent and MRIs, to potentially mostly RV and some LV, so different 4 clusters in the patient with arrhythmogenic cardiomyopathy. And then, when they analyzed the genes, they could actually do 4 different phenotypes in arrhythmogenic cardiomyopathy, which range from mostly isolated right ventricle to mostly left ventricular or biventricular involvement. So it's quite important to understand. We knew essentially from the beginning, from the first description, that there may be some left ventricular involvement in arrhythmogenic cardiomyopathy, but now we really have a paradigm change, and we now have moved from, we know that some of the genetic mutations will preferentially affect the right ventricle. Some of the genetic mutations may actually affect the left ventricle, and there's quite a significant amount of left and right biventricular involvement. And we know that there are specific gene changes that potentially do that. The pathways seem to be relatively common. There's significant overlap, but also some specific differences in the pathways may go into the one or the other direction. So we now differentiate again between the right dominant phenotype, and this is an MRI scan from a patient with a right ventricular cardiomyopathy. And you can see here the enlargement of the right ventricle, the aneurysms, the left dominant phenotype, and this is another MRI where you can see here the scar tissue circumferential around the left ventricle, where you have an early and prominent left ventricular manifestation. But then you have also the biventricular phenotype, and you can see here both right as well as left ventricular involvement with fibrosis. Here is a thrombus in the right ventricle as well. Now, in terms of symptoms, so there are various symptoms. Mostly there are palpitations, and there can be blackouts. There are atypical chest pains and shortness of breath. And in more dramatic presentation can be myocarditis or even cardiac arrest and sudden death. There are extra cardiac manifestations, which we now recognize and know much better. And this is the woolly hair from a patient with cardiocutaneous syndrome, the Naxos, the Carvajal syndromes, typically have the woolly hair and palmoplantar keratoderma. But as we now have gone much deeper in the genetics, and we can analyze more and more patients, we now see that there is significant variation as well as in the skin changes. And it doesn't have to be as significant. It can range from a simple hyperkeratosis to potentially just curly hair and erythrodermia. So there's significant amount of variation in the skin changes as well, depending on the mutation and potentially the expression of the disease. Now, what we are doing as cardiomyopathy specialists in clinic in most patients, or in all patients with arrhythmogenic cardiomyopathy, really is 5 things. And the most important thing at the first stage is really to establish the diagnosis. And it's important to establish the accurate diagnosis, and tools that we use for that is history taken from the patients, and more. It's quite important to assess the exercise history as well. Family history is very important here, as well as the physical examination. And then we will proceed to some more advanced techniques like an ECG or a signal average ECG, Holter imaging studies such as an echo, an MRI, and sometimes also with a stress echo. And the diagnosis sometimes may be quite easy, like in this patient where you can see the typical changes in the skin and in the hair. You can see the typical T-wave inversions on the ECG, which is a hallmark of arrhythmogenic cardiomyopathy. And you can see here the dilatation in the echo and in the MRI with the aneurysms and ventricular arrhythmias. But sometimes it may be quite more difficult than that. And here are the task force criteria that a panel of experts sat down and put together from different studies before. And these criteria are used to establish a diagnosis of arrhythmogenic cardiomyopathy or in individuals. Sometimes you can see there are major and minor criteria. There are 5 different categories that we have 6 different categories that we actually need to gather points from. And this involves structural changes. Again, the MRI with the aneurysms can involve histological changes, the fibrofatty replacement on biopsy, can involve electrical changes, which is the T-wave inversion on the ECG, or even smaller changes, such as a delay in the electrical activation of the right ventricle, or this is the classic epsilon wave in arrhythmogenic cardiomyopathy, and certainly arrhythmic features such as the classical arrhythmias that we see in arrhythmogenic cardiomyopathy. So sometimes the diagnosis is difficult and needs more criteria. Fortunately, we have made a significant progress in the last years, and we have moved from the echo, where we can, with our machines improving continuously, to the MRI scan and tissue characterization. And this has made significant progress in our understanding of arrhythmogenic cardiomyopathy, but also all of the cardiomyopathies in general. And here, this is, one of the first presentations where we actually thought that triangle of dysplasia, what we were used to seeing at the time in the right ventricular angiography. But you can see here with the MRI scan, actually, this we now know that's a bit different, and actually the places that we thought that the arrhythmogenic cardiomyopathy preferentially affects are now a bit different. So our understanding continues to develop significantly with the imaging techniques. And here you can see I've brought some images from an echocardiogram from a patient with isolated right ventricular cardiomyopathy. This is the right ventricle. You can see here the dilatation and the impaired function, so there is not as much contraction. Same patient here from the 4 chambers view. You can see here, this is the right ventricle, which is shows. I mean, you can imagine there's a lot of scar tissue there, potential dilatation of the heart of the right ventricle. And this is an MRI scan from a patient with arrhythmogenic cardiomyopathy. You can see here again, very dilated right ventricle with quite a few regional wall motion abnormalities in the right ventricle, some aneurysms. All these being hallmarks of the imaging criteria in arrhythmogenic cardiomyopathy. And as I said, now we generally very, very rarely need to actually do a tissue diagnosis and endomyocardial biopsies, because the MRI actually can give us quite significant information. And here, where the arrow points, you can see the white along the right ventricular wall, which is the scar tissue in the myocardium, the right ventricular myocardium. And here, where the other arrows point, the black line is essentially the fat infiltration. So we do have specific sequences on the MRI, which enable us to assess a lot about the tissue characterization and what the tissue, the myocardial fibrosis and fat replacement can be in ARVC. Important component of our diagnosis and our management is genetic testing. And the guidelines obviously recommend that patients with arrhythmogenic cardiomyopathy are genotyped. Usually the person that needs to be, or the patient that needs to be tested is the one with the more profound phenotype. So this is what we call a proband, potentially the first patient, or the most profound phenotype. And then essentially this always has to involve both the desmosomal genes, but extended panel of non-desmosomal genes, which now we now know can cause very similar phenotypes. And the analysis ideally should be happening in specialized genetic centers. Another important aspect of our management is really the risk of sudden death, and this is very important, as we know that sudden death in ARVC is well recognized, and these are data from the US registry shows around 4%. I can just focus on the green. So 4% of sudden deaths are due to arrhythmogenic cardiomyopathy in Italy, where it's a much better recognized phenomenon. About 23% of the arrhythmogenic cardiomyopathy, or 23% of the sudden death may be secondary to arrhythmogenic cardiomyopathy. And these are some of the UK data. You can see here ARVC is responsible for 10% of sudden deaths. Actually, when the pathologist says that we don't see any changes in the postmortem and we go on and analyze families and we do more extensive analysis, we will find more patients with arrhythmogenic cardiomyopathy here in this 30% of unexplained sudden death. And again here focus on the moderate blue. So around another 10% of this 29% will be arrhythmogenic cardiomyopathy. And this shows sometimes the importance of the importance to look at the family, but also the difficulty in diagnosing arrhythmogenic cardiomyopathy occasionally. Now, over multiple studies in the past, we have developed criteria for risk assessment, and we have some minor risk factors and we have major risk factors, and we can put the spectrum and the risk of every individual in a specific spectrum along our risk stratification, and potentially change our management. So some of the major risk factors would be arrhythmias that we pick up on the Holters, unexplained syncopes, and more significant phenotype, essentially. And the Johns Hopkins group, along with an international study, they actually made a calculator for that, where you can find on the internet. You can plug in some of the data that we find, and which then gives you a very specific number of risk, which can be used to risk stratify patients with arrhythmogenic cardiomyopathy and play a significant role in their management and decision making. And obviously, one of the most important points is the indications for a defibrillator in arrhythmogenic cardiomyopathy. And they now have developed some algorithms for that. And generally, people that are at higher risk will have an ICD, and this is a very class 1 indication. And quite a few people with the intermediate risk may be considered for ICD, provided that they have some of the major risk factors, as we discussed just now, or some of the minor risk factors. And some of those may be young age. I mean, young people tend to have more significant arrhythmic burden, as well as potentially male sex or being a proband, and some data from electrophysiological analysis. And we can see here, this is a study back in 2010 from Italy, where they implanted defibrillators, one of the major studies in arrhythmogenic cardiomyopathy. And you can see here, this is the risk of events without a defibrillator implanted and the survival over the course of about 6 years. And you can see here that implanting a defibrillator essentially abolished this risk almost to zero. Now, just to simplify things, who should get an ICD, really? And really in ARVC, it's individuals with a prior cardiac arrest or hemodynamically unstable cardiac arrhythmias. I think this is a no-brainer in most of the times. And mostly individuals with a diagnosis of ARVC which fulfill the task force criteria and are proband. So essentially, these people will have enough risk factors to justify an ICD insertion. And then selected family members of ARVC who have high risk factors. And this is the reason why we see patients in the cardiomyopathy clinic every year to risk stratify. There are two types of devices, as you may know. One is the classic intravenous system, which we have used for decades, with a single or dual chamber ICD, which has a lead that ends up in the right ventricle. And there's the newer system, which now exists almost for 10, 15 years already, and which is a subcutaneous system, which is essentially in a totally external system implanted under the skin, with just one lead running along the chest wall and the breastbone. Now, this is obviously, given the fact that there are less things going in the bloodstream and in the heart, the risk of complications is much less. We now know that it's equally effective in preventing malignant arrhythmias. The downside being that there may be a slightly higher risk of having inappropriate shocks. We know that from different trials. So actually getting a shock when you not need one. However, with the progression of the devices and the algorithms, we expect that to reduce significantly in the future. And why it is important to risk stratify patients and to know who is the patient actually that will need a defibrillator. And you can see here, these are two very important studies that actually analyzed the anxiety that the device causes. We know that this is a significant event, especially as people with ARVC may be quite young. And we know that people with younger age who actually had an ICD shock, which can be quite a dramatic event, and having a recent implantation of the ICD will generally tend to have much significant or higher levels of anxiety and depression. And this is why it's very important to find the people that actually need an ICD and justify for one. And this also shows how important the psychological support in this patient group is. Important point another is to reduce the symptoms and prevent the progression. So I've put them both together because essentially it's our interventions there work in both ways. And I think one of the important things is really exercise. And what is the evidence that we have significant amount of evidence now that exercise and arrhythmogenic cardiomyopathy is an important factor. So we know ARVC is mostly a desmosomal dysfunction, and the desmosomes are, connect the cells together. And during exercise, the RV pressure increases, up to threefold. The right ventricle can dilate and increase the wall stress. All this puts pressure to the desmosome, which already has a genetic abnormality. So many ARVC patients, especially those that present at young age, are high-level athletes. So we generally see early expression ARVC in people that have that exercise a lot. And exercise is a common trigger of arrhythmias and sudden death in ARVC patients, this patient population. And there's a significant amount of human and mouse studies now that demonstrate the provocative role of exercise. And this is how things work in general. So you have the desmosome, and then you apply a lot of mechanical stress potentially with exercise, and this leads to a mechanical disruption of a desmosome, myocardial damage. And as we said, there is the reparative process from our body itself, which tends to be either scar tissue and fat replacement. And this can lead to a dilatation of the right ventricle, potentially with disruption of the structure, but also as well increase of the arrhythmias. And you can see here, this may happen in very significant, with a very significant amount of exercise, even if there's no genetic background. So you can imagine what happens if there is actually a genetic background already there. Now, this is a study, a very recent one that I looked into family relatives who are gene carriers. And we know that exercise is important for the expression of disease there as well. And you can see here, these are the task force criteria points that individuals scored. So essentially, red ones are the people that they had less disease, and red ones are and green one are the ones that express more disease. And you can see here in the lower spectrum of the exercise, the disease was much milder. And the same was with the ventricular arrhythmias. So both the exercise increased both the ventricular arrhythmias as well as potential structural and electrical changes in gene carriers. And this is the case as well in patients that actually express have arrhythmogenic cardiomyopathy, so they already diagnosed with that. You can see here, this is the amount of exercise that people used to do before they were diagnosed. And so patients who actually exercised more, they tend to have more arrhythmic events, and the same is with exercise after the diagnosis. So generally, both the exercise before but after the diagnosis will play a significant role in the amount of arrhythmic events, as well as the severity of the phenotype. Now, does this mean that we cannot exercise at all? Well, no, this is not correct. But so this is a very helpful table from the current guidelines for sports, which shows essentially how high the intensity of some sports is and how how frequent we can actually exercise there. And most of the low intensity sports we can actually do much more common, and this is probably quite helpful for a lot of individuals. A little bit about heart failure and whether this is we don't see much heart failure in arrhythmogenic cardiomyopathy. This is we do some symptoms, and this is a study from the symptoms of heart failure, but there was not really much volume overload, and the symptoms tend to be relatively classic, that the ones that we know. And so this means that it may be very under-recognized. So female sex and some ECG changes in the left ventricular side were associated more with heart failure. And from those patients, around 15 patients, so a relatively small number, ended up transplanted in the course of a years. And this is the data from heart transplantation. Essentially, in the course of quite a few years, they had 18 patients that were transplanted. So male patients tended to be more common there, and they had a very long onset of symptoms, at least 24 plus minus 13 years. And the reasons mostly for transplantation was heart failure, and some of those had arrhythmic causes for that. A little bit about the ventricular ablation. In case of arrhythmias, which we cannot really control with antiarrhythmic medication, ablation can be a very successful way to control the ICD shocks as well as the arrhythmias. And in arrhythmogenic cardiomyopathy, we may need both an endocardial, so this means both wires in the heart, also sometimes external wires around the heart to ablate. But this is a very effective way of controlling both the arrhythmias as well as the ICD shocks in patients with arrhythmogenic cardiomyopathy. And you can see this is a study where it shows quite significant reduction of the events after a year. And this is the combined approach of endocardial and epicardial ablation, and the significant improvement it goes to the arrhythmic events. So just to summarize on the treatment, essentially it's important to stop exercising, no competitive or frequent high intensity endurance exercise. So take beta blockers. This is a mainstay of the therapy to reduce the arrhythmias, but also the ICD interventions. And take ACE inhibitors if there's heart failure progression. The antiarrhythmics may have a significant role in a few patients, in a significant amount of patients with arrhythmogenic cardiomyopathy, both to reduce the arrhythmias, but also the shocks and therapies of the defibrillator. And in some patients who cannot be controlled with the antiarrhythmics, the catheter ablation may have a significant role there. And finally, one of the important points is really the family screening. And this is the reason why we see the family screening in the cardiomyopathy clinic, and all first-degree family relatives should undergo a clinical evaluation every 1 to 3 years. And then we start around the age of 10 to 12 years. A genetic diagnosis may help us significantly to exclude or include patients to the ongoing family screening, and this should be part of the screening as well. And generally, we screen patients with a pretty similar investigations as patients with ARVC. As we said, in the last years, we have seen significant developments in the research around the arrhythmogenic cardiomyopathy, and we do understand quite a lot about the physiology, and this obviously leads to potential ways and development of therapies and treatments. And this is a study that shows that part of the pathogenesis in arrhythmogenic cardiomyopathy may be actually in the inflammatory response. And this is one of the Italian studies that shows that there is a part of autoimmunity. So essentially, our body has not been exposed previously to some of the antigens that we see with arrhythmogenic cardiomyopathy, turns itself again against some of our heart, and this may be something that we can influence. And this is another study which shows the same, that there is essentially part of autoimmunity potentially in right ventricular cardiomyopathy, and that therapeutic modulation of this immune response can salvage the phenotype and improve things. So there's definitely quite a lot to go. And here's just very briefly the pathogenesis and the complex mechanisms involved in arrhythmogenic cardiomyopathy. But as you can see, this opens the window for quite a few targets, some such as the GSK3B inhibition, some anti-inflammatory therapy, anti-TNF and NF-kappa beta inhibitors, which we have shown to have a central role in the pathogenesis of ARVC. So it is quite it is likely that we're going to see a lot of new medication and therapies in the future. So I will just conclude with this schema, and essentially it's very important to establish the phenotype of arrhythmogenic cardiomyopathy. Now we're talking about arrhythmogenic, not only right or left, and based on the symptoms, but also with assessment with all the tools that we have, including genetics. And once we've done the establishment of the diagnosis, then we need to assess the risk of sudden death, the progression of the disease, and potentially proceed to ICD insertion, treat appropriately with medication, but also heart failure management, psychological support, proceed to gene testing and potentially alternative causes that may be involved in the pathogenesis. And as we said, the future, I think, is open to quite a significant amount of new therapies that potentially will come up. I want to thank you for listening, and I thank my team. I think we've got some time now for questions. Let me just bring this up. All right, so I'll start with one of the first questions that says, so other than exertion exercise, what other things could cause progression of ARVC? Well, that's a good question. As you can see, there's quite a bit of, exercise is a significant part, but there are other factors that potentially may play a significant role, and this may be things that generally we're not able to control. And this may be things like, our sex, essentially, or the genetic background. Give me just a second, I just lost the question. Yeah, so the genetic background, so multiple mutations potentially mean that the progression of the disease may be more significant. So essentially things that we generally are not able to control. So what is able to stop the progression of disease? Essentially medication and therapies, and prevent the arrhythmias. So next one, hi. Can you say if there's anything we know about ARVC this year that we didn't know last year? I think the significant progress is made this year in terms of the future perspectives and the understanding of the pathology. I don't think there is a step up in the knowledge that we had, for instance, last year. Although we do have significant, more important understanding in the genetics of arrhythmogenic cardiomyopathy. So there are other genes that have been added, and there is stratification of patients with arrhythmogenic cardiomyopathy. So definitely that is very important. So genes like lamin C, for instance, or desmin. We now are much closer in understanding the phenotype and how to risk stratify and treat these patients. But also, we now know that there's quite a significant background in the pathogenesis of arrhythmogenic cardiomyopathy that we have been able to understand and potentially develop for the future. So yes, there is potentially not a significant step up in the knowledge, but there is significant increase in some of the aspects of arrhythmogenic cardiomyopathy that will help us in our everyday clinical management of patients. So I will take the next one. So how do you know that you have ARVC rather than DCM? What is the difference, and is it possible to be labeled as DCM when in fact you have ARVC? So I think this is a very important question. You may have realized through the talk that there is significant overlap between the two phenotypes of dilated cardiomyopathy and arrhythmogenic cardiomyopathy. And sometimes we may label somebody as DCM, or we may label somebody as ARVC or arrhythmogenic cardiomyopathy. Really, the main difference is going to be the amount of arrhythmic events and how we risk stratify people. And in the end of the day, it's probably not as important to put a name to the disease, as long as we're doing the correct things to actually recognize that that one of the individuals and the phenotype may be more arrhythmic and poses a more increased or significantly increased risk for the individuals carrying the disease, rather than actually giving the name. So the next one is, I'm asymptomatic with ARVC, and I'm mindful the exercise threshold is around 120 beats per minute, and I do monitor with a Fitbit, but how much exercise is too much? I regularly swim, walk the dogs quickly every day. So I think I've shown you this table, which we can find, and there is on the website of the British Heart Foundation, as a Cardiomyopathy UK. There is information about the exercise. In general, avoid competitive and high intensity endurance sports. Think about a little bit like cigarettes, essentially, with a lot of exercise and with high frequency is the one that plays a role. Now, low intensity things such as the walking the dogs or low intensity exercise, which we can do more frequently, is not as harmful as endurance sports, such as marathon running, competitive sports, cycling, which should be avoided in arrhythmogenic cardiomyopathy. All right, so we've got another 5 minutes. So I have a question here about do coffee, what's that? Sorry, I just lost it. Does a lamin mutation suggest ARVC? So lamin is one of the genes that is quite complex. It's a big gene. It has lots of phenotypes, and lamin mutations that are associated with cardiac involvement generally have a significantly arrhythmic phenotype. So the answer is yes, lamin is part of the arrhythmogenic cardiomyopathy phenotype. It has some differences compared to what we describe as classic ARVC, but generally lamin is considered as a very arrhythmic gene. Do coffee and alcohol intake have an effect on the progression of ARVC? Probably not as much. It may affect the arrhythmias. So both coffee as well as potentially stimulants, alcohol, they can affect the arrhythmias, and we know that potentially a significant amount of events may occur after alcohol consumption or after. It may not be a cup of coffee, but a significant amount of caffeine ingestion as potentially, as well as stimulants, may affect not only the dangerous arrhythmias, but some of the supraventricular arrhythmias like atrial fibrillation or similar arrhythmias. So yes, the answer is probably not the progression of arrhythmogenic cardiomyopathy, but it can provoke arrhythmias. So if you have ALVC, so left ventricular or left dominant arrhythmogenic cardiomyopathy, do you have to take the same precautions regarding exercise as someone with ARVC? Just to keep it simple, I think the answer is yes. It has to do with the genetic background. So most of the information on exercise comes from studies in patients that actually carry genes, desmosomal genes. So the answer is if you have ALVC, you've got one of the desmosomal mutations, that's desmoplastic, which is the classic one for that, then the same precautions regarding exercise apply with ARVC. I mean, independently in every cardiomyopathy, we generally, if somebody is affected, we recommend that they avoid competitive sports. So yeah. So can you define what you call the hot phase, please? So yeah, I'm sorry so hot phase essentially is a phase where somebody may present, especially in ARVC, we now recognize that a lot. It may be a time period in the disease progression where people may present with more symptoms. It may be palpitations, maybe some atypical chest pains, or even potentially some sudden death. So this is a sort of acute phase in potentially the disease progression. We don't really know why it's happening, or we have a slight idea about it, but it generally is an acute phase in the disease, which will probably become quiet after a while. But we can recognize some phases where they are more acute and associated with symptoms and potentially events in arrhythmogenic cardiomyopathy. This is what we call a hot phase, and we generally think this is associated with the progression of disease. I think we've got a couple of minutes more now. So there's a question about if you have a lamin mutation, is this laminopathy, or is muscular dystrophy needed to be visible to be laminopathy? Well, I mean, if you have a lamin mutation, you need to have some sort of, the laminopathy is a word, essentially, it involves some pathology. So there needs to be a phenotype there. Either it's going to be a cardiac phenotype or a muscular phenotype. So lamin, as we said, does a lot of things. Now, having an isolated lamin mutation without a phenotype, so absolutely everything should be normal, then I think I would have trouble calling it a laminopathy per se. But definitely it would be somebody that potentially may develop something. So the answer is as we said, mutation necessarily doesn't mean that somebody will develop a disease, but it generally, especially in lamin, we are very careful with patients that carry these mutations.